In this module, I will be discussing the chapter which I have shared from Jonathan Abrams. The reason I just want to show the reading material itself and clarify is because some of the important concepts in atrial septal defect is not that clear in many books. So this book gives a very good outline about the concepts related to atrial septal defect. First thing, we know that the secondum type is the most frequent type of atrial septal defect. But you need to be clear what we mean by the secondum type of defect. So here what you actually see is you are able to see the normal defect which is called the fossa ovalis, and the location of the fossa ovalis when it is defective we call it as ostium secundum defect. Ostium primum is something which is close in the lower part. So here you have the fossa ovalis, that part is normal, but the lower part of the intraatrial septum when it is defective it is called ostium primum. Quite often this is also associated with a valvular regurgitant lesion there because basically they come under the endocardial cushion. Sinus venosus is high up here, close to the entry of the superior vena cava. So in this particular defect, you can see that the pulmonary vein, the right superior pulmonary vein also gets drained into the right atrium. So this site you need to really understand before you can really decipher more on the atrial location of the atrial septal defect. So first thing you have to understand in this is, you may think that atrial septal defect is present at birth. So we may be able to appreciate the signs of atrial septal defect during early childhood. That is not true. I think that part is what is clearly explained here. So one thing what you need to understand is minimal or absent physical finding of ASD in infancy and at very young age. So the reason is because it is given in the initial part. At birth, the right ventricle is thick. Right ventricle is thick and it is stiff. Therefore, the compliance of the right ventricle is very poor. So which means that the pressure in the right ventricle and right atrium, it takes time for it to recover to normal adulthood. So during that time, though there is a big defect in the atrial septum, shunting will not effectively occur. In other words, though there is a septal defect, the high flow through the right ventricle and through the pulmonary region does not happen. So that is why it takes a longer time for the changes to occur. So the systolic murmur, the pulmonary ejection systolic murmur of ASD and the wide fixed splitting of S2 occurs later and not in the initial part. So this point you have to be clear in the description. So quite often we conventional teaching also sometimes they tell that when the atrial septal is defect in childhood, then they will allow it to be closed over a period of time. Mostly atrial septal defect is not diagnosed at a very young age. So usually it becomes obvious only beyond 5 years of age. Unlike ventricular septal defect, which may be able to, especially when the defects are small, it may be very obvious in the early childhood itself. So that is a point you need to remember. So this entire thing actually explains only that. This entire page actually it explains only that. So it keeps telling the amount of blood which may go. You can see that it's shown that normally it is 4 to 5 liters per minute output out of the ventricle, but in this case the flow is so high that it can exceed up to 10 to 20 liters. So in initial phase, it is more like a volume overload to the entire pulmonary circulation and again to the right atrium and right ventricle. So this point you please understand. So these two paragraphs, you please go through it. Determinants of shunt volume. You will get a very clear idea about how the shunt volume behaves in the early part, then how it reverses, and what is the amount to which it is actually occurs. Second is pulmonary vascular disease. Now, though the pulmonary arterial circulation is very high in a large ASD, it takes a very long time for the actual hypertrophy. We know that in mitral stenosis, you have a initial passive phase, and then there is an active phase, and there is a phase where the arterial media undergoes hypertrophy. That becomes a kind of an irreversible changes, where the intima becomes proliferate, ultimately leads to a irreversible. That takes a very long time in atrial septal defect. That is one of the reasons why even in adult patients, closure of atrial septal defect helps in the prevention of many of the complications, especially atrial fibrillation and sometimes other types of supraventricular arrhythmia, which can occur in atrial septal defect. It can be avoided. So that point you please understand. The pulmonary arterial, it takes a very long time. Though in this particular literature, they have told later childhood, most of the time we see it in well into adulthood, 30 years, 40 years. Only at that time it will be picked up. Before that, they will have some other evidence of cardiac symptoms. So invariably it is diagnosed secondary to arrhythmia or effort intolerance. Now, one thing you need to remember in this paragraph where atrial septal defect in adult is given is 40 years is the thing. So beyond 40 years, atrial septal defect gets diagnosed if it is a small atrial septal defect. Large atrial septal defect, mostly it presents before 40 years of age. So that is the cutoff you have to remember. So if the patient is 50 or 60, you are going to bring in atrial septal defect, think if you can give a differential diagnosis for the problem, because the findings of atrial septal is very non-specific. You will understand it at the end, by the end when I discuss all the other signs of atrial septal defect. So above 40 years, be careful when you tell the diagnosis as atrial septal defect. But there is an exception. So when the patient has underlying hypertension or when the patient has coronary artery disease, that can cause secondary rise in left atrial pressure. So the initial shunt may be small, but over a period of time, what will happen because of the additional causes which you get in atrial septal defect, as the age increases, the individual may have other things. So here two things are mentioned here. So one is hypertension, another is coronary artery disease. So this can actually increase a left to right shunting. Okay. So this is something you need to really remember. And right atrial pressure rises only after the left atrial pressure has reached a really abnormal level. So it takes time. So initially the left atrial pressure keeps on going up, and then you may get the additional changes which you can actually get. Now, one thing you need to understand is that when the right ventricle fails, the right ventricle ultimately fails, the right atrial pressure will become relatively low because the right to left shunting actually goes down, isn't it? So when the right to left shunting actually goes down, I am telling in the setting of the change in the pulmonary pressure. So technically, it will actually decompress the right heart. So entertaining right ventricular failure, again in a patient suspected of having a reversal option, should be avoided. There is a point I'm trying to tell here. So when you tell that there is a possibility of a reversal option due to some signs, which we'll be discussing later, do not bring to the diagnosis of right ventricular failure, because in that case, the findings will change a lot. So regarding presence of mitral valve prolapse, there is difference of opinion there. So because you may hear a systolic click both in mitral valve prolapse as well as in atrial septal defect. So quite often the discussion of this mid-systolic clicks come into the picture. So in general, there is association of mitral valve prolapse with atrial septal defect, though this book discusses it. Most cardiology books have not really accepted the concept of a common embryonic defect. So when there is endocardial cushion defect, you will get a regurgitant lesion, more so of the tricuspid valve, and also the mitral valve, depending on the extent of the lesion. Generally, association of mitral valve prolapse with atrial septal defect is not actually well accepted. Then coming to the general appearance, there is no typical habitus, though some books have given including this, that is not accepted. And if you look at the syndrome which is more commonly associated, as you can see, the whole Toran syndrome, Ehlers-Danlos, these are very rare. Okay, so have that in mind that most the atrial septal defect is often an isolated finding. Though you need to look for other signs, most of the time it is an isolated finding. Regarding arterial pulse and blood pressure, the arterial pulse and the blood pressure is usually not affected at all in atrial septal defect. One exception is when there is a atrial fibrillation. Already I told you, due to chronic dilatation of the left atrium or the right atrium, they are more prone for arrhythmias, commonly atrial fibrillation. So in the regular examination, chronic arrhythmia, the only thing we see is chronic atrial fibrillation. But remember, it can also have transient irregularity of the pulse, like occasional atrial premature beat or a supraventricular tachycardia may occur. So paroxysmal rhythm disturbance, either mild in the form of atrial extrasystole or more severe in the form of supraventricular tachycardia is possible. Now, jugular venous pulse in atrial septal defect is actually, I would say, a very fascinating point in discussion of atrial septal defect, which is something which we also see in the bedside. Actually, this JVP in atrial septal defect is not there in many of the other books. So it's better to understand what the author is trying to tell. Now, what you need to, I think the JVP, I have told that in convention, the A wave is the bigger wave than the V wave. In a normal individual, I am telling. But actually, if you look at the left atrial V wave, in normal individuals, left atrial V wave we didn't discuss at all because we are talking about the JVP, it's all right atrial. So in an individual with the intact atrial septum, the left atrial V wave is actually larger. Okay. So this is partly reflected due to the continuity of the contraction of the right ventricle and left ventricle and the variation in the filling pattern. I'm not going into the reason why the left atrial V in healthy individual. Now, in atrial septal defect, even if the JVP is not elevated, if you suspect atrial septal defect, you place the patient in say 30 degree and try to study the waveform using the two things I told you. One is the carotid, another is the S1 and the systole of the heart. You can identify these waveforms. Now in atrial septal defect, this even the JVP is not elevated, the V wave will be bigger than the A wave. So that is a one valuable point you can actually remember in practice. So let me just explain this. So this table actually sums up what you need to really remember. So Generally, A wave is greater than V wave. Okay, so when that is the case, you are not going to look about large. So shunt is usually small. But when you are talking about a large left to right shunt, then V wave is technically larger than the A. So this point you just remember in mind. So in case the discussion is brought in, sometimes they may bring in the morphology of the waveforms of the JVP when you are having a patient with atrial septal defect. Just remember this concept. No need to have a great understanding of the entire thing which is given there. Try to really look at the A wave, V wave difference alone in patients with atrial septal defect. Don't bother much about the X and the Y descent. Okay. So quite often this is not discussed as a cause for prominent V in individuals. So that point I just want you people to understand in this. So that is with reference to the JVP. Don't bother much about the wide distance. See, all these italics, what is given in the books, please go through it properly, because it will really help you to understand which is the core concept given in the book. Next is the right ventricular impulse. Now, quite often we know that whenever there is a right ventricular impulse, we attribute it to the pulmonary hypertension. As we see in say mitral stenosis, we know that we really worry about it only when there is a pulmonary hypertension. But what you need to understand here is it can occur without pulmonary hypertension. So large VSD without pulmonary hypertension, it can produce a hyperdynamic parasternal impulse. So you need not actually attribute the, so let me just show the part more clearly for you. So that is what they have given here. Although most large ASDs without pulmonary hypertension produce only a brief hyperdynamic parasternal impulse, large shunt on occasion will result in a sustained right ventricular lift. So even in the absence of pulmonary hypertension. So they have given two types of lifting. So here you need to really understand that in a patient with atrial septal defect, when you are able to appreciate a parasternal lift, it does not always mean that the patient is having a pulmonary hypertension. Just the extent of the shunt itself can lead on to right ventricular impulse. This is another point you need to remember there. But you may ask then, how will I differentiate whether the patient is having a pulmonary hypertension or not? How can I attribute this? If I tell that this is due to high flow, how can I tell that the patient is, this is not due to pulmonary hypertension? That we will see in the subsequent. So what happens to the auscultatory findings in atrial septal defect when pulmonary hypertension sets in? You will get a better understanding here. Right? Now, another thing you need to remember that the palpability of the P2. Now, this again is something what is very similar to what I have just explained. So palpable P2 again we will always attribute to pulmonary hypertension, isn't it? So that's what given here. Palpable P2 and is another common finding. Subjects with ASD and should suggest the presence of some degree of pulmonary hypertension. So I'm just reading this paragraph. Nevertheless, palpable pulmonary artery activity and increased P2 in the second or third left space can be seen in large left to right shunts in the presence of normal pulmonary artery pressure. So this is another finding which you need to be careful. So one I already told you, you may have a lift of the parasternal region even when the pulmonary artery pressure is normal. Second thing I have told you that the pulmonary artery pressure can be normal, but still the P2 can be low. Now, first sound, you can go through the discussion which is given in this book, but remember, first start sound is unaltered in atrial septal defect. That's a better way of remembering it. So these things are little controversial in the discussion. That's the reason I wanted to clarify which part of this chapter should be ignored a little bit. So I'm not telling it's wrong, but it's not widely acceptable. Coming to the second sound, very important. We all know that the most important finding in atrial septal defect is wide fixed splitting of S2. So that we all know. Okay. Now, what is the mechanism? Here one part is there which is called hangout interval, which for some reason is not properly described. So I'll just clarify on that. It's nicely given in this hangout interval. Now in atrial septal defect, I'll just put what happens in the right ventricle. So you have the right ventricle. Okay. So I'll use a pointer preferably. I'll just try to explain the entire paragraph here. First thing is that it's mentioned that there are two things: large right ventricular stroke volume and increased capacitance of the pulmonary arterial blood accounts for the wide splitting of S2. Right? Now the dilated pulmonary artery has a low impedance and a long hangout interval. You may ask, what is the hangout interval? Now normally, when the pulmonary artery has a normal impedance, let's say the pulmonary artery has a normal impedance, right ventricular emptying occurs. You know that the right ventricular pressure will keep on come down during contraction of the right ventricle. At a particular point, the right ventricular pressure will be less than the pulmonary arterial bed. Okay, so when the pulmonary bed pressure increases more than the right ventricle, the pulmonary valve closes. That causes the P2, isn't it? Now, for the P2 to occur after A2, the pulmonary artery impedance should be normal. So what will happen when the impedance less down becomes less, pulmonary bed impedance is less, the pressure doesn't translate quickly. So what happens in atrial septal defect, because the pulmonary artery impedance is, even after the pressure of the right ventricle has decreased, pulmonary artery will not lead the valve to close quickly. So there will be a delay. The pulmonary valve will not quickly close, but there will be a delay in the, so that is called the hangout interval. So this hangout interval gets prolonged because the pulmonary artery impedance becomes less, because the impedance has to be normal, because then only the pressure will suddenly change. That doesn't occur here. So that is what is explained here. Let me just read it out here. The dilated pulmonary artery has a low impedance, so it will not quickly result in the closure pulmonary valve. Now, and P2 follows A2 by a prolonged interval. So that is the reason the P2 closes later. There is one more reason also. So this is not the only reason. So you cannot tell that the problem in the increase in the hangout interval as the only reason for the delay in the P2, which is fixed. We know that in this presence of septal defect, the inflow of the right atrium and the left atrium becomes reasonably normalized. So that is what they are trying to explain here. In a normal heart, changes in the degree of right and the left ventricle filling during respiratory cycle are approximately equal in subjects with AST. It doesn't vary in patients with AST. So therefore, the P2 does not move away from A2 in respiration. Now, why does it occur? So any increase in the inspiratory right ventricular return also tends to decrease because the shunt occurs, isn't it, constantly. So when the right ventricular inflow increases or the right atrial inflow increases, this will block the shunting from the left atrium to the left ventricle. Therefore, the filling is decreased, right? So it automatically counters the shunting, and therefore usually the amount of filling in the right atrium and the left atrium is almost same in both inspiration and expiration. Therefore, that inspiratory increase does not occur at all, right? So when you are asked about the mechanism of wide splitting, two things you should tell. In atrial septal defect, there is progressive increase, chronic increase in the right ventricular stroke volume. This leads on to decrease in the impedance of the proximal pulmonary vascular bed. So when the impedance in the pulmonary vascular bed decreases, the closing of the pulmonary valve gets affected, because impedance should be normal, because pulmonary impedance drives the closure of the pulmonary valve when the right ventricular pressure decreases at the end of the right ventricular systole. So that does not occur here. Since the pulmonary impedance is less, there is slightly a delay in the closure of the pulmonary valve. Therefore, the hangout interval is longer and the P2 follows A2. So that is for the distance, for the wide. Okay. So wide fixed S2, isn't it? So the reason for the wide thing is the prolongation of the hangout interval. Now, why is it not changing with inspiration expiration? That is the second paragraph. The filling pressure is countered in the inspiration expiration, beautifully explained there. So the filling pattern is almost roughly constant. So right ventricular and left ventricular ejection is roughly equivalent, whatever may be the phase of the respiration. Therefore, the relationship between A2 and P2, they maintain a constant relationship. Okay, so the P2 gets delayed because of the hangout interval. A2 P2 gap is maintained because of the changes which occurs in the inspiration expiration, which balance both the atrial pressures. I think you understood this concept. If you have not understood, you put your doubts in your query in the discussion class forum. I'll explain it a little bit more clear. So, okay. The other factors I think you should be knowing: when the heart rate decreases, again A2P2 can worsen. When there is a bundle branch block, that can get defected. Physiological variations can occur. So this is something you can just remember. Okay. Now, one more critical part what you can understand here is the Valsalva maneuver. This is again very, if you do it in the bedside, you'll know how valuable it is. Now, Valsalva maneuver, we know that you try to increase the intrathoracic pressure and also an attempt to increase the peripheral resistance. So when you do the Valsalva maneuver in healthy individual, the A2P2 fusion occurs. This is a very good tool. Whenever you have a doubt, you try this. Okay, in the strain phase, the fusion of A2P2 occurs. Don't bother about what happens in the release. During the strain phase, the A2P2 fuses. But in atrial septal defect, A2 and P2 will move apart during the strain phase. Right? So this is because in atrial septal defect, since there is a connection between both, Valsalva maneuver will be constant. You're not going to have the fusion at all. Okay. So the A2 and P2, A2 will occur earlier because the LV filling diminishes, but the RV filling remains the same. So the P2 will be delayed. So this is a very good tool. So using Valsalva maneuver at the bedside is a very good tool. When you have a doubt, there is a split S2. I'm not sure whether it is just a physiological split, or I'm not able to convincingly tell that this is wide and fixed split. Using Valsalva maneuver is a very good tool at the bedside. This is very quite reliable, and you can also include it in the discussion. Right? So that is the next thing I want to tell more clearly here. Okay. Again, at this point, I think already I told you, the second pulmonary sound, P2, can be loud even in the absence of pulmonary hypertension. That point I've already told during the palpability of the P2, so I'm skipping that. Now, differential diagnosis, I think you will be knowing already. I told you, just dilatation of the pulmonary artery for no reason when there is a right bundle branch block. So I'm not going into that. As far as third and the fourth heart sound, just remember that the S4 may be seen sometimes, but for all practical purposes, don't entertain S3, S4 in atrial septal defect. Most of the other cardiology books have not discussed that part here. Now coming to the pulmonary ejection sound. Okay, already I told you that ejection click may be present in a large proportion of patients with AST, right? So now pulmonary ejection click, as I told you, it can be confused with the mitral valve click. Using position is a good tool to utilize, but just remember this, that the click is actually felt in a substantially large number of people, and when the pulmonary hypertension is present, the probability goes up. So this again, the point we need to remember is that when there is a pulmonary ejection click, so the likelihood of a pulmonary hypertension increases. Okay, just remember this point. Ejection click and pulmonary hypertension correlation. I just want to make you understand here. Now coming to the murmur, right? So one thing you need to understand is here is the murmur is actually produced by the turbulence, because in AST there are two things. Initially it's a volume overload. After the pulmonary hypertension sets in, it becomes a pressure overload. So that is something you need to always remember that. So it may be heard in the left second to the third space. Sometimes it may also be heard in the fourth space, and it is crescendo, decrescendo. All these things you will be knowing, right? Now with reference to the murmur, there are few things you need to remember. The murmur almost never has a thrill. Okay. Classical thrill is not that common in atrial septal defect. You can sometimes get it in pulmonary hypertension, but in general, most literature tells that whenever there is a thrill, whenever you are able to actually appreciate a thrill, so here it's given here. So 4, anything more than 4, you should suspect associated pulmonary stenosis. Another exception you can remember is occurrence of a severe pulmonary artery hypertension. You can just remember that. So what you need to really remember here is that generally thrill is not present here. Why I am telling is that sometimes you may have a ventricular septal defect which is there, that is projecting a systolic murmur, a small kind of a defect, and you may sometimes confuse it with the atrial septal defect murmur. So that is a reason I just want to make you understand that this not related with the thrill often. Okay. Now, associated pulmonary stenosis, I am not going into that because it's not commonly seen in practice. Now, coming to tricuspid regurgitation. Now, tricuspid regurgitation, already I told you that in patient with atrial septal defect with pulmonary hypertension, there is a right ventricular dilatation, a functional TR is present. So, seeking for a tricuspid murmur is a good effort to be put in these patients. So they may not have a typical pulmonary ejection murmur. Why I am telling is that once the hypertension sets in, pulmonary hypertension sets in, what happens is the shunt murmur decreases. So here this line I just want you people to remember. Patient with pulmonary hypertension severe enough to produce a TR will not have a typical pulmonic ejection murmur of AST. This is what I was trying to tell. So when I told you, isn't it, loud P2, palpable P2, ejection systolic murmur, right ventricular impulse, all these things can occur even without pulmonary hypertension. But how to differentiate that with the occurrence of pulmonary hypertension? So all these things can occur in just ASD. There is no need for pulmonary hypertension to occur. So how will I differentiate it? Whether it is due to pulmonary hypertension, because pulmonary hypertension can also produce the same thing. RV impulse will be there, palpable P2 may be there, ejection systolic murmur may be there. So here the point is that when clinically meaningful pulmonary hypertension sets in, TR may set in, the intensity of the typical pulmonary ejection murmur will decrease. So this is in contradiction with many of the other discussions of pulmonary hypertension we have made in many other diseases like mitral stenosis or mitral regurgitation, right? Then second comes the tricuspid flow murmur. This is possible. Tricuspid flow murmur through the septal defect is quite common. Quite often this murmur is even actually confused with the mitral stenotic murmur. So this I just want you people to remember. When there is a very high flow, you may have a mid-diastolic murmur which is heard in atrial septal defect. So the MDM split in the S2, you may confuse that with mitral stenosis. You will tell that the splitting of the S2 is due to opening snap, and then the flow murmur, what you actually heard through the tricuspidal is the MDM of mitral stenosis. Parasternal heave may be present, P2 may be palpable. You have a tendency to really tell it is a mitral stenosis. But you need to remember that atrial septal defect can very closely mimic a mitral stenotic murmur. Okay, so I think this takes us to one table which gives us more or less a clear. So all these things are just written explanation. I'm not going into that much. So all the other things already I told you. Once the pulmonary hypertension sets in, you will get a prominent, which is non-hypertensive ASD is not seen. So automatically the A becomes prominent. So all those things are summarized in the table here. Okay, so this sums up all the important things you should remember in a patient who has, so far I've been telling only the signs in individual who have so here JVP is one thing I told. So what is given here? Increased A wave amplitude, large V wave. So this is what we are telling. So what I told initially was the change between the V wave and the A wave. So in general, the A wave amplitude is bigger. So here, once the pulmonary hypertension sets in, the usual pattern recurs. I told that V wave will be bigger than A wave in a patient with atrial septal defect without pulmonary hypertension. That gives us an idea. But here the reverse happens. What you usually get in pulmonary hypertension happens here. A wave amplitude increases and large V if TR is present. This is a usual finding we get in pulmonary hypertension. So that finding comes back when there is a pulmonary hypertensive atrial septal defect. Second is, you may get a palpable P2. Okay, P2 may be loud, but the point you need to really look here is that splitting is often narrow. Often narrow. Okay, this given can be wide, but most often splitting is narrow. Absence of ASD systolic murmur. They have even given an absence of ASD systolic murmur. That is the murmur to the pulmonary valve. So you can tell that intensity will decrease. Tricuspid insufficiency murmur is common, and that pulmonary regurgitation murmur is common, and the diastolic murmur also goes down. Okay, so summarizing all these things, what I want you to understand is that when you discuss a patient with atrial septal defect, have in mind, does the patient have pulmonary hypertensive atrial septal defect, or is it a non-pulmonary hypertensive atrial septal defect? So you need to look at both as a separate entity. Both may have similar findings, but to tell about the pulmonary hypertensive ASD, the critical points you need to remember is the waveform which you study in JVP. If you can identify it, it will be well and nice. It's a fascination in the bedside, I would say. Then concentrating on the width of the S2 narrow S2, decrease in the intensity of the ejection systolic murmur in the pulmonary region, more dominance of the regurgitant murmur of tricuspid insufficiency, and to some extent the pulmonary insufficiency. So that is the thing what you need to have in mind. So just have these concepts in mind. These pages what you see is a very good literature on the atrial septal defect. So maybe you read it again once again. Read everything, nothing wrong, but try to concentrate on the concepts which I told. The broad thing is that how will I determine an ASD is having a pulmonary hypertension? How will I determine an ASD as a does not have a pulmonary hypertension? Read the entire material in that angle, so you will be able to understand in a better way. So now you please read it back, read again the literature, then you will get the concept of the entire right.